Go ahead and get started again. So you've been hearing about the patient panel in the LIC for 2 days. Many of you, certainly all day today, and for those of you that were here yesterday, hearing about it yesterday too. This is Dr. Ann Frank. She's a LIC director at Denver Health and a med peds physician and a longtime friend. And we're going to be talking about maximizing the LIC patient panel experience for meaningful student, faculty, and patient experiences. And we have an all-star cast who's going to do a lot of storytelling for you. But for the first few minutes here, I'm going to geek out on a little bit of LIC learning theory about why we think the patient panel matters. And then we're going to really talk a little more in depth about the role of the students' patient panel in the larger educational arc of the LIC. And we're going to spend some time both by their stories and your ideas around identifying strategies to facilitate longitudinal patient experiences. So we're going to do about just 5 minutes of my geeked out part and then 20 minutes of some student storytelling. And then we'll be in some breakout groups back along the wall like you guys were before, but I hope you'll mix it up, find a different spot than you were earlier today. And as you go through the whole day, at the end, I hope you're going to be thinking about new precepting strategies that you're going to try specifically with this facilitating the panel concept in mind. So we've talked about the LIC and LIC learning for a while. There are now some papers that really talk about how learning happens in the LIC. Like what is happening that gives us these good academic outcomes, these patient-centeredness outcomes, these outcomes that have to do with empathy through the course of the LIC. And we think that that has to do, not just we, the experts, think that, that this has to do with knowledge integration over time, specifically around longitudinal variability. And what I mean by that is seeing the same patients in different contexts, seeing the same conditions in different clinical settings, but particularly that piece about seeing patients evolve over time across different kinds of settings and seeing how their illness and their patient's experience of the illness evolves. And then we talked about continuity. So that doesn't make it into, or doesn't escape any paper on LIC learning theory. This is also important though. So this paper came by David Hirsch, who is kind of considered to be the father of the LIC, at least in the United States. He's a really storied medical educator out of Harvard. And this paper was called The Role of Role, Learning in Longitudinal Integrated and Traditional Block Clerkships. And they did focus groups with students at Harvard who were in LICs and who were in traditional block models. And what they found was that although LIC and block students reported serving in important roles in supporting their patients and sharing information about their care, only LIC students consistently described opportunities to grow into a doctor role with patients. The high level of integration of LIC students into care systems and their deeper relationships with preceptors and patients enhance their motivation and feelings of competence to provide patient-centered care. So that's what we're trying to get at, and that's part of why we are putting such emphasis on the concept of the patient panel. So what is it? Who should be in it? What is the panel? How do we make this work? How do we make it come to life? So you may have seen this earlier today if you were here from the very start. This is the core concept. Dr. Adams shared it this morning. I'm going to revisit it. Students are serving as advocates and navigators for their patients throughout the clerkship year and are attending visits, admissions, procedures, deliveries with patients that they've selected to be a part of their panel. And students will have a minimum number of cohort patients in each specialty that they are expected to follow over time in care venues. And we're hoping that they'll get to this magic number of 3. And sometimes that's where it stops. And sometimes, as you'll hear from these students, it goes way beyond and much deeper than 3 kind of touches on the patient and the healthcare system. This is what we ask of them in the LIC. You can look this up. I'm not going to spend much time on it. I know that Jen flashed it up earlier, but it is to say that we have some standards and we also have space for students to follow their interests, their connection with patients, their sort of passions to develop these relationships. So who is helpful here? Like when you're thinking about who makes a great LIC panel patient, the biggest thing I can say is look for patients who are going to have a lot of touches on the healthcare system, right? If somebody only comes in for an annual visit once a year, that is not going to be your highest yield panel patient. It's very hard to follow them when they don't come in and they don't really need the healthcare system right now. But a patient who has a new diagnosis may have a lot of follow-up with their primary care team or with their new specialty. They may go to a procedure or a biopsy or a test. And those are all opportunities for our students to engage with them, follow them, meet them where they are. Stable chronically ill patients who are coming in frequently for serial checkups. In my clinic, they give me the Boomerang Award because they say I bring my patients back so often, because that's my main way of keeping them out of the hospital. So for a lot of my chronic multi-morbid patients, like they're in there every month because that keeps us a step ahead of the hospitalization. Those patients are great patients for panel patients because they come in frequently and it's easy to schedule follow-up with them. Dr. Frank is a med-peds doc, and she has found that the first year of life is a wonderful time to engage a student with a new panel patient because infants come in frequently for follow-up care, monthly or beyond. I don't remember anymore. A lot. They come in a lot. My kids are 10. And then end of life also. And actually that is something that we ask of them to try and engage with a student, with a patient who's at the end of their life and follow them through that trajectory. But that's another patient who's going to have a lot of contact with the healthcare system. It doesn't have to be that the student is following them just to hospice. They can go with the palliative care team to their house. They can be there when a home visit is happening. So thinking expansively. And then surgical trajectories have a lot of potential and power here. And Nikolai is probably going to tell you a story about a patient that he saw pre-op, op, and post-op. And that trajectory can be really powerful for our students as well. Socially complex patients. So in our focus groups that we were telling you about in the last hour, some of the students said, I only met them in person once, but we talked on the phone a lot because they kept not coming to their appointments. So every time they didn't come to their appointment, I'd give them a call. And so that matters, right? Like that learning is still happening, even though the patient actually isn't coming in to see the doctor. And so these socially complex patients have a big opportunity for students to lean in and get involved and support them. Patients, this is Nikolai's words as well. This is your quote, Nikolai. Patients on the cusp of a big change who are contemplative have the opportunity for a student to really lean in and make a difference in helping them follow through in that kind of motivational interviewing framework. And then we always want them to follow their heart and their curiosity around patients they meet and things they want to learn more about. So what are we asking them to do? This is the list that we give the students, okay? So we want them to familiarize themselves. We want them to be the expert, okay? We want them to be the patient's expert, to know the most about them and to take an active role. And that means following up on studies and consultations, discussing next steps, taking charge of communicating those next steps to patients and to consulting teams. They may not be able to get to every touch that patient has on the healthcare system, but really trying their best to get into those spaces and following the patients from the outpatient setting to the inpatient setting. So for example, if you have a patient that is going to be admitted, they may not be on their inpatient immersion week, but they can still go see them. They can still be a part of that care. We actually asked them to track it too. So this is not something that you're responsible for, but I did just want you to kind of have a sense that the students are tracking it on the back end. Who are they following? What's happening there? And their LIC directors are actually looking at this quarterly and reviewing and trying to kind of help them coach and tailor those experiences. When I talk with our students in Colorado Springs about how to do this, we talk about when do you fit it in, right? Like you're in clinic a lot of the week. So I encourage them, and I'm sharing this with you so that you can be kind of familiar with these tips. I encourage them to plan wraparound time. So maybe they don't have EMR access from home. Some of our community-based sites don't have places where they can get on a VPN and see that record from outside of the clinical setting. So they may need to get there a little early to follow up, or they may need to be game to stay a little late to follow up on what happened with patients from the week before, 2 weeks ago. We do have time built into their week. And in here, it is maybe we don't have, it's the red time. It's the red time up there is the patient panel and self-directed learning time. That is built into their week, and it may feel like their time to go on a bike ride or take a nap, but functionally it's designed to be time to be following up on these patients and trying to have some wiggle room to get to follow-ups and other appointments. So we really encourage them to dedicate some time to that. And then we talked earlier about intersession teaching. Like we want the students to be talking with you about how do we coordinate off session? Do you mind telling me when that lab result comes in? Do you mind letting me know if you end up hospitalizing them? Because I'll go see them. So planning that intersession communication time proactively and ahead of time. This can happen anywhere, okay? So it doesn't have to be continuity that always happens in the clinical space that you live in. They get to go to other cool places. You stay in your clinic, but they go all over the place. So we encourage them to think expansively about where continuity can occur. And I tell them, you may have to coach your preceptor about this because it's not the way most of us trained. So, you know, talking with them in advance about how they can embrace the telephone, about how they can embrace the EMR. And if you have an EMR that they have a basket in, don't forget that you can forward them stuff. All right. You can forward them charts, you can forward them messages, you can forward them labs, you can ask them to act on things. Not all of us have that capability in our EMR, but if you do, use it. All right.
Okay. Does this work too?
Yeah, okay. So tremendous amount of gratitude for our student panel. Thank you for coming in on your free time to teach all of us how you did this and how you created such meaningful relationships with patients. So we'll start maybe just by introductions, and you can kind of say name, maybe LIC experience, and anything else you want to share with the group. And you guys have a mic? Okay.
Oh, there we go. I'm Frances Vernon. I was in the Denver Health LIC this year, and I'm excited to be here to talk to y'all.
And I'm Lily Kong. I was also in the Denver Health LIC this year.
On? Yes, okay. I'm Samantha. I was in the Denver Health LIC last year, and I'm going into OBGYN.
I'm Bree. I'm from the Colorado Springs LIC, and I will be doing anesthesia.
I'm Matt. I was in the Colorado Springs LIC as well. I'm applying internal medicine.
Dr. Cassidy already outed me. I'm Nikolai. I was in the Colorado Springs branch LIC, and I'm headed into internal medicine.
Heather and I were very strongly impacted by each of your different stories. And there may be other stories that we don't know about your other longitudinal patients, but by at least one story from you all. So I think the first question or direction to the panel is tell us about an impactful longitudinal patient relationship you developed during the LIC.
I can start. So my patient experience that Dr. Cassidy and I have talked about multiple times is one that I had pre-op, during the operation, and then post-op involving my surgery preceptor, Dr. Willard. And I met this patient in a pre-op clinic visit. And he was one of those times where you see their picture on Epic and then you walk into the room and they look like a totally different person. And so he had a right AKA following a diabetic foot ulcer. And since that time, he had really turned his life around. So he had lost about 100 pounds. He was exercising as much as he could. He had made a lot of really good life changes and unfortunately had developed an anal rectal abscess that we were working him up for that had been kind of continually causing him trouble. And so pre-op, I was evaluating him for that. And because it's surgery, I needed to ask, do you smoke? And he was like, yeah, I've been cutting down, but I'm still smoking 4 to 5 cigarettes a day. And I could tell that he had made all these really great changes. And so I was like, okay, so what's stopping you from stopping smoking? And he goes, I've tried cold turkey before and it just hasn't happened. And so I asked him, would you try the gum or the patches? And he goes, yeah, sure. But can you prescribe that for me? I was like, oh yeah, I can get Dr. Willard to prescribe you some smoking cessation medications. She loves that as a surgeon. And so internal medicine I went and put in the orders for her, and so that she had the ability to co-sign them. And then I set it up because she has me present in the room in front of the patient. And so the way I presented it was to improve his post-op healing. I think we should prescribe him smoking cessation medications. And I already put in the order so you can just co-sign them. And she gave me this look of like, ugh, fine. And so we sent in the order, and then I saw him the next week for his operation, which he had scheduled so that I could be there. And so I walked in for that like pre-op the day of, and I walk in and I'm checking in and I see the patch there on his arm. And he's like, I haven't smoked since you gave me the patches. And he had made an appointment with his PCP so that they could take over the like smoking cessation meds. And then we saw him 2 weeks after that. And I walk into the post-op clinic visit and I see him sitting there munching on the gum. He's got the patch on and he still hadn't smoked. And I very admittedly smugly in my presentation to Dr. Willard was like, and he's having a great post-op recovery and he hasn't smoked. And so we have seen him a couple times after that for an issue with his new prosthetic that we were able to get him connected with. And I just really took a lot of like motivation from the LIC panel patient experience, because he had already made these great changes in his life and he just needed that next little bump to transition him. And I really don't think if I, as the student, didn't take that opportunity to have Dr. Willard get forced into some primary care as a surgeon, that this patient would have at least maybe not have had as good of a post-op experience, but also wouldn't have felt as connected to us as his surgical team, and feel as safe and like approachable with us moving forward. So that's my story.
Nikolai, thank you so much for sharing that. I had just a quick follow-up question and invite any questions from the group, but do you have any idea if Dr. Willard since may have used those orders or used that experience to also prescribe gum or patches for other surgical patients where their outcomes would be improved?
So I also overlapped with the next class of med students that got like assigned to Dr. Willard, and I told them this story. And so I was like, you can do it, like take the shot. And so they both want to be surgeons. And so I'm like still working with them on doing primary care in surgery clinic. But I do think Dr. Willard is more open-minded to this idea of not just seeing like the checkbox of, oh, they are a smoker, and that being like a negative thing for them with their like what we worry about for their post-op recovery, and like seeing that as an opportunity to at least ask the question of, would you be willing to like take some meds or try something to decrease that, because that would make my life easier as a surgeon. That's how I frame it to her, and I think that works.
Couple of hearts here in the chat. Dr. Willard's a tough cookie.
Yeah. She's real touch and feeling. Other questions?
Up to you. Yeah.
I think Dr. Frank asked me to talk about a particular experience I had this year that happened to overlap with Dr. Frank, even though she wasn't my pediatric preceptor. We did our immersions in the beginning, so right about this time last year, and I spent a week on labor and delivery. And on my last day, I'd seen a lot of C-sections and hadn't really been a part of any vaginal deliveries. So the team was really helpful and got me set up with a woman who was coming up, came in by ambulance, was already 10 centimeters dilated. And when we got to the room was alone. And she was Spanish speaking only, and very much in active labor. And I went in with, it was actually a midwife running the delivery. And I kind of took my position beside her. I don't have children yet, and I had never labored with anyone, because often most people have someone with them. And so it was a really unique opportunity for me to support this woman through such an incredible experience. And so I stayed by her side. She delivered a healthy baby girl, which she'd said she wanted. And I went and visited her postpartum later that day. And something was kind of off when she came in, and the team, we couldn't really figure out what was going on. And I'd spent a lot of time getting to know her and her story, and who she was, and, you know, kind of in between contractions, took it, you know, an opportunity. We just got to chat about a lot of different things in her life. And then unfortunately, due to circumstances in her life, she left the hospital and didn't take the baby with her. And so the baby was in the NICU for a couple of days, and then eventually got placed into the foster care system, even though the woman wanted to put her up for adoption, was too scared, I think partially related to documentation, to sign any official paperwork for adoption. So because she wasn't able to do that, the baby went into the foster care system, which is the clinic that Dr. Frank runs, conveniently at Eastside. And so I put the baby on my panel, and started to go to all of the baby's visits as soon as we had finished our immersions. And the baby, by the time I came to the first appointment, the baby was in its second, her name's Alani, her second placement, home placement. And I knew nothing about, I knew nothing about just the care of a baby in general. So it was a huge learning experience, like we talked about, of just the first year of life. But also, I really didn't know a lot about the foster care system and what it looks like for a child to receive care in the clinic that specifically focuses on taking care of kids in the foster care clinic. And I actually got to know Alani's foster mom, who's now, she's in a foster to adopt placement, which is very exciting. And Angela, her mom, and I have spoken a lot at our different visits. I've been able to share what I can and what was appropriate about Alani's birth mom, which to Angela, and I think maybe one day to Alani, will be helpful for her. And then throughout the year, Dr. Frank and I had our visits, and then I actually got invited to go to a court hearing for termination of parental rights in February. So I was actually in my pediatric immersion, but they let me step out for an hour, and it was on Zoom. And that is like a totally unique experience that I really feel like, because of the LIC and because of having this patient on my panel, and just building this deep relationship with both, of course, the child as much as possible, but also this foster family. I really felt like I got to experience and be there with the foster mom as well. And we also did a home visit. We do a home visit as part of our program. So I decided to do the home visit, and Dr. Frank and I were able to go into Angela's home. She has one other biologic child, and actually has one who should be due any minute. I suppose this week, I think. So has her hands full, and just kind of learned all about her experience in foster care and why she decided to get involved in it, and how many children she's had in her home, and what those experiences have been like for her and her partner, and just kind of seeing how their family, what different families look like in different homes. And I think, for me, Alani will obviously always hold a very special place in my heart, and definitely be a patient that I will absolutely never forget. And one decision we talked a lot about was the foster mom had asked for my contact information to put in her baby book, because they did receive termination of parental rights and will move forward with adopting her. And it was an interesting discussion I felt like we had about professional boundaries, which I never expected to kind of have as a medical student. But ultimately, for me, I decided that that was okay. And so I don't know if in 20 years I might hear from Alani, and I tried to write down in every reflection I could all of the memories I have of going through labor with her biological mom, so that someday, if that's something she wants to know or hear about, I'll be able to share with her.
Thank you so much, Frances. Are there questions, or should we move on? Everybody has a really good story, so I feel like thank you.
So I have two stories. I'm going to talk quick so I can get through both of them. But the one that I was invited to talk about was I was in my pediatrics clinic, and a patient came in as like hospital follow-up. She had gone to an ER outside of Denver Health for abdominal pain and was discharged and was coming to follow up and was still like in excruciating pain. And just based on history physical, I was worried about ovarian torsion. Talked to my preceptor about it, and we spoke with the patient and her mom and just said, we think you should go to the emergency room to be reevaluated. And so she went to the emergency department. I finished up with that clinic and then actually went to the emergency department then. And luckily things happened slowly in the ED. So she was still there. And I was able to kind of work with then the ED doc to kind of go through that workup. And turns out they didn't see ovarian torsion at that visit, but she did have like quite a large ovarian cyst. And so then she was set up with follow-up in GYN. And so then I actually didn't get to go to that appointment, but at that appointment and the ultrasound, they gave her the option, because it was so large, to have it removed, and she elected to do that. And so I was able to then be in on the case with Dr. Adkins actually to see this cyst removed, and it was a gnarly cyst. It just was really cool from a learning perspective. There was like part of a tooth in it, and then so that was really cool, getting to see like kind of from start to finish, and then ended up seeing her back in pediatrics clinic. And it was just really cool, the continuity of care. And I think that like there's not many specialties where you would get to see something in every aspect, like going to your primary care doctor and then seeing them in the emergency room, and then seeing them in, operation planning, and then in the operation post. And so it just was really cool to be able to actually see like a medical story truly from start to finish. And then my second experience, which was more like emotionally impactful, in my first medicine immersion, I met a woman who had Guillain-Barré from like post-COVID. And this was like super early on in COVID times. And, she got IVIG in the hospital, and I just really enjoyed her. And so spent a lot of time with her when I was there, like during downtime in the day, and just got to know her really well. She was discharged. And then I ended up like checking, on Epic where my patients were, and saw that she was back in the hospital. And so I was like, oh, great, I can go and see her again. This was like, 3 weeks after the initial admission. And so I go and see her, and she's back because her symptoms started coming back. And so she needed to get another IVIG round. And I went in just to kind of chat with her, and she just seemed different. Like she seemed more anxious and just not the same as she looked last time. And so I kind of sat down and I was like, are you okay? Like you seem not okay. And she just started crying and was like, I don't want anyone to forget about me. Like I'm back here because I couldn't get a follow-up appointment. No one was calling me back. And I just feel like they're going to forget about me. And I just like grabbed her hand, and she like grabbed my other hand. And then we just sat on her bed, and she cried. And I was like, I'm going to make sure that no one forgets about you. And I just decided that like, that's my job as an LIC student that has this extra time, is that I'm going to make sure she's not forgotten about. And so when she was discharged from there, still having trouble getting follow-up in neurology. And so then I was like, I'm just going to be annoying. And then I started calling neurology clinic like twice a day, like, hey, it's by this patient. Her numbness is now up to her knees. So what do you think she should do now? And then the next day it's up to her thighs now. And then finally, they were like, okay, we'll call her when we have an opening. And so then she was able to be seen just a couple of days later. And I went to that appointment with her. And she was like a very kind of shy, like reserved person. And so then I kind of also was like, all right, this is my job. I'm going to make sure that she tells this doctor everything that he needs to know, because it took us some work to get in there. And I really just like stood my ground and made sure that this doc like heard what had been going on with her. And I just realized in myself that I was like, okay, I would not stand up for myself like that. But when it came to this patient, I was just like, I don't care if I'm annoying, because this is unacceptable to me. And I like feel so strongly. And I made her this promise that they wouldn't forget about her. And so she ended up doing a little bit better and then didn't show up to a follow-up appointment. And so then I started calling her, and her number had been disconnected. So I was really worried, but eventually you have to kind of just move on. And then like months later, I was driving to my ED shift and I get a Facebook notification that I have a message from like XY. And I was like, there's no way that it's her. And I opened it up, and sure enough, she'd found me on Facebook and sent me this long message like, I'm sorry I didn't show up to my follow-up. Like I had to move quickly for a family emergency, but I just wanted to say thank you. Like you saved my life. And I just wanted you to know that I appreciated that so much. And that is, I think, going to be one of the top situations I've ever had with a patient. And it made me feel like I'm actually going to be a doctor one day. Like, I'm not just going to be a med student forever. Like, she didn't reach out to, the neurologist to say thanks for saving my life. She reached out to me. And so I just, that is my favorite story of the LIC for sure.
Yeah, I feel like we do owe everybody like a standing ovation after each of these stories. Maybe in the interest of time, we'll keep questions for the end and just keep passing things along.
Okay. Yeah. So thank you for everybody that's shared so far. These are really cool stories to hear from. So I met my patient on my first third year rotation ever on like my second day. So everybody that went through third year, I'm sure you can remember how anxious you are as a third year medical student, brand new baby. My internal medicine doctor had me go see a patient that had just been admitted. And her story was that she came in the night before because she was super fatigued and like having all these kind of wild symptoms, ended up being very, very anemic and was found to have a really large cecal mass. So that's why she was admitted up to us. And so whenever I kind of got the brief overview of who I was going to see on my way to her room, I was kind of treating it as a patient vignette. It didn't feel like I was about to go talk to a human, because I was like, what kind of questions do I need to ask her? Like, how am I going to sound like intelligent whenever I come back to present to my preceptor? Like, I was having all these checkbox like kind of items whenever I was walking to her room. And sorry, I get so emotional. Whenever I got to her room, the thing that struck me whenever I went in is she was only a few years older than me, and she had just gotten this cancer diagnosis that's like completely altering her life. And she was on Zoom, so she's a special ed teacher, and she's on Zoom watching her students graduate because she couldn't be there that day. She was supposed to give a speech for them, and was completely missing out on this entire special aspect of her life. And here I was, like, not even realizing I'm going to a patient's room that just got a cancer diagnosis. And so I stopped in my tracks, and the questions that I had wanted to ask her, that didn't really even happen, because we started talking about life and like how derailed she felt, and kind of like how she feels like she doesn't know where to go from here. And it was so cool being a med student just in general, because I could talk there for hours with, well, I mean, my preceptor didn't want me in there for hours, but I was in there. I was in there for kind of a long time. But it was neat. Like I was in a unique position to get to know her a little bit and ask a little bit more in-depth questions about her concerns and what she was afraid of in the future, and like how I could assist her in that way. And over the course of the week, I was obviously able to round on her for the rest of my internal medicine immersion, or my week with her. And I was also able to go in and be a part of her bowel resection, and I got to be the one to place her report. And after that, I kept following up with her to like go sit in on her chemo infusions and talk to her, just kind of almost as a friend, like kind of as a friend, because I felt like she needed some sort of support during that time. And our classmate actually taught us about a word called sonder. I don't know if you guys are familiar with that. So I think it's recently made up. That's what Austin was saying. But yeah, but the idea of it is that, or it's the realization that the people you meet, like the strangers, have like in-depth, complex lives that you will know nothing about. And like silly me, like walking to her, like treating her as a vignette whenever she's like so complex. Like she has these like 2 really cute dogs and 1 child, and is this special education teacher, and is like living this like really complex life that I would have never known about unless I had the time to ask her, or even just cared to ask, because I wasn't going to ask that. I was going to be like, what kind of, are you having bloody bowels? Like, are you, all these different symptoms? But I got to learn about her life, and like, it was a great opportunity for me to remember that like all of my patients in the future are going to have these like individual complex lives that like I want to know about, like maybe not for hours on end, but like I want to know about it. So it was cool getting to be in this and follow with like a lot of my other preceptors were really great about letting me miss half of a day so I could go sit in on her chemo appointments. And I don't know, I was thankful for that. Oh, she did. I don't know if I can cuss on the microphone, but she invited me to her frick cancer party, which I was also unfortunately unable to go to, but I still do keep in contact with her. She's doing great. She hasn't had any recurrence of her cancer so far, and I think she's doing really well, kind of adapting back to life, and she's been able to go back and teach again. So things are looking up, and she's happy. So.
Okay, I can keep it moving. That's awesome. So my panel patient, I got to meet in my internal medicine clinic, who my preceptor was actually Dr. Cassidy. And my patient was presenting new to us, or new to me at least, with a complaint of abnormal uterine bleeding. And this had happened the week prior. And at that appointment, Dr. Cassidy had ordered labs, just screening labs to look at, everything, but in that was a CMP. And what we found on her CMP was that she had elevated liver enzymes. And so this is the context that I was entering the room with this patient. And I think when Nikolai said that thing that was on the previous slide about entering the patient's world at the moment of on the verge of a new diagnosis, or on the cusp, I think is the word you used, that was exactly how I was entering the room with this patient. But I don't think I realized that. And so I walked into the room, and it turned into a whole conversation around alcohol use and her severely elevated liver enzymes, and really her end-stage liver disease. And so not only was I thrust into meeting this patient for the first time, but it was this sudden, like, holy cow, I have to build some trust very quick. She seemed hesitant at first. It was a very uncomfortable for the first 10 minutes talking to this patient, but quickly realized that she was a human being. She had feelings, and I was here to help her and kind of be there with her as we talked about this new diagnosis that she had. related to her alcohol use. And so luckily at the end of that, at the end of that visit, we were able to get a same day consult inside the same hospital, up with GI to talk about liver biopsy. And I think like some of the coolest things about the med student role is I was able to be like, oh, I'm not going to see any more patients this morning. I'm going to join this patient. And encouraged by Dr. Cassidy, but also by my interest, I joined the patient upstairs to the GI suite, and almost felt as if I was walking to that room as a different role, not necessarily as medical student, but as patient advocate, where I knew all of what we had discovered already in the internal medicine clinic, more of the background of the social story, and I was able to carry some of that information to the GI attending, albeit I didn't get out of there without getting pimped, but that's just the risk we run, is getting questioned. And after that, this was in about November, and as I'm sure we're all aware, the holidays are pretty stressful for people who have alcohol use disorder. And so I had the opportunity to then follow up virtually, not by telehealth, but by phone call. And this was the first moment I was like, wow, this is a panel patient that I can remember for the rest of my life, because she answered the phone and called me Dr. Matt. And I mean, I'm still just full of imposter syndrome. I'm like, that is still a dream. I'm not Dr. Matt. But to her, it was the first realization. I was like, whoa, I have kind of been with this patient in many different contexts. And now she's just calling me to tell me that she's been sober since we first met. And she hadn't started drinking again. And then fast forward after winter break, this was intentional, but I did completely, in the days of everything else going on in third year, had forgotten, and I showed up in Canyon City, Colorado. So I'm in this Colorado Springs branch, where I was, and then I had to travel for my OB/GYN rotation in Canyon City. And I'm sitting at the desk and I looked at the schedule and I was like, wait, I know this patient. Where do I know them from? Oh my gosh, it's my patient from internal medicine. She had presented to us with abnormal uterine bleeding, and we had taken the internal medicine route and talked about her transaminitis. Which, I mean, I'm applying into IM, so. But we did the right thing and we referred her to OB/GYN. And so I was like, oh, sweet, I get to see her in OB/GYN clinic. And the MA walks out of the room and was like, oh yeah, no students. And I was like, we're tiptoeing around MAs all the time. I don't want to make anyone angry, but I was like, did you tell her who I was? She was like, no, why would I say that? I was like, oh, can you please tell her it's Matt, like it's Matthew from Colorado Springs. And she opens the door again and I hear her through the door. Oh yeah, this student says his name's Matt. And she's like, no way, it's Matthew. Like, it's Dr. Matt, let him in. And that was like, I was like, oh my gosh, this is awesome. She goes, but not for the exam. I was like, that's okay. I don't need to, that's okay. So I went and my preceptor was finishing up with the previous visit, and she walks out and we're kind of doing our pre-visit chart review. And instead of my attending looking through the chart, I was actually able to give kind of a verbal handoff to my preceptor, which I thought was so cool. I was able to say, this is the stuff that we're working up in medicine. She has this liver failure. She's in the context of uterine bleeding. She's postmenopause, all this stuff. It was able, I felt like I was just filling in these cool puzzle pieces, and I was geeking out because she knew I wanted to go into internal medicine. And then we went into the room, and it was like, as if my attending had known this patient from the minute that I had met the patient. And the smile that I got from this patient that we had both seen was just beyond me. It made me full of gratitude. And since that visit, I've been able to call her a couple more times in some of my free time in internal medicine clinic through Doximity. And every time she's been telling us how long she's been free of alcohol. And I still get the Dr. Matt and the imposter syndrome still doing this, but it was, absolutely a patient that I'm never going to forget.
Lily, you want to bring us home?
So my patient that I'm going to talk about, his name is Bill. So I met him on my surgery immersion, and I think when I picked him up as my patient, the whole surgery team was like, oh, he's kind of a stinker. And I was like, okay, not gonna have any internal biases before going into the room. And like he was there for a recurrent diverticulitis, and I, like got to know him a little bit. I was present for his surgery. When we went into the abdomen, what we took out like looked not great. It looked like cancer. And I continued to follow him after his operation while he was still in the hospital. And I just came to realize that he was the type of patient who just needed a little more support. He like needed a lot of repetition to sort of process information and like to understand everything that was going on. And I don't think he was getting a lot of that. Sort of the pinnacle of all of this was that when he was told of the cancer diagnosis, it was stage 2 adenocarcinoma. He told me later that the surgeon walked in, told him he had this diagnosis, got a phone call, and then never came back. He like walked out of the room and just never came back. So I spent the rest of the hospitalization just like talking to him, like talking through the diagnosis with him, and like discussing, what this meant for him and how he was doing with that diagnosis. And we talked for like hours. Like he taught me how to play poker, which I don't remember how to do. We talked about like all these different things, and I visited him like every single day, even when he wasn't on my team anymore. Unfortunately, I didn't get to see him on the day of discharge. I like was in another surgery and tried to make a mental note to remind myself, but he had been discharged before. I was out of the surgery. And so I was like, okay, like, that's fine. Like, I'll see him at his follow-up appointment. And I couldn't make his first follow-up appointment. And he also was scheduled with hem-onc for the cancer diagnosis. And then I tried to go to his subsequent appointments and like would wait there probably for longer than I should have. But he didn't show up to a bunch of them. And this was kind of all complicated by some social background, which is that he lives in an RV and doesn't have a phone. And every week I would have this like eureka moment. I was like, oh my God, I'm gonna call him. And then I was like, he doesn't have a phone number. And I was like, maybe I should like send a letter like by snail mail to the address in his Epic. And that also didn't make sense. So I kind of like thought I would never see him again. And then he had another post-op appointment with the surgery clinic, and I showed up and he was there. It was just like so good to see him. He had been doing so much better. He had gone to the chemo appointment and said that they wanted to start him on chemo, but he declined because it wouldn't add that much survival to his life. And he was exercising, he had gained weight, he was feeling really great, and he was really motivated to get his ostomy reversed. He had had a Hartman procedure. I was able to see him for the Hartman reversal and follow up with him after. And the final visit I had with him was actually in the primary care clinic. We finally got him a primary care doctor. And he was kind of talking about how he had was feeling really tired from this second giant abdominal surgery he had. He was like, I'm feeling really fatigued. I want to get back to working out and getting back into shape. Is there any, supplement or pill or something that you can give me to kind of help me through that? But I could tell that he, just from knowing him so well, I could tell that when the doctor was like, yeah, fortunately there's no magic pill, but we could check your thyroid, and you did have they found something in his cardiac exam, and you did have this big surgery, so we can check some of those things with a Holter monitor. And he's like, no, I don't want any monitoring for now. But I could tell that he just wasn't really convinced and didn't feel listened to. And so when the resident went to staff with the attending, he turned to me and he was like, Lily, what do you think? do you think that there is a supplement or something I could take? And I was kind of like, Bill, like you have this huge surgery on your abdomen. Like they went in and like put you back together. And I think it's okay for you to like take some time to process this like big trauma that your body has had and like listen to your body. It's okay if you're sleeping a little more. And like, you know, doctors are just doing their due diligence to make sure nothing else is wrong. But, you know, you like give it a little bit of time. And I think like they don't want to give you any supplement or anything that they don't know how that's going to affect your healing. They don't know like what's in it. And we kind of want to make sure you're on the best path possible for healing. And I think that if I hadn't seen him throughout the course of the year and like known what he really needed to feel supported and listened to, like I would not have known to do that. And I wouldn't have kind of picked up on like him feeling a little distrustful of the physician, especially given the history of like the way he was told his cancer diagnosis. And so I think for me, like it was kind of such a small conversation, but it really cemented this sort of like relationship that I had with him that allowed me to understand him as a person and like what he needed, not only within the medical system, but also also out of it. It was just like such a pleasure to be able to see him get better as well. Like every time I saw him for a visit, he gave me this big hug and he was like, "It's so good to see you." And he would ask me about what was going on in my medical training. And we had like a real relationship in that way. When I saw him for the final time, he like gave me like 5 hugs and he was like, "Thank you so much for everything you've done. Like you've really been an angel in this." And yeah, I just don't think I'll ever forget him. So yeah.
I have so much appreciation for both the wonderful storytelling that you all did. I feel like we should have made this like a storytelling hour rather than more of a panel. And I think we will all agree that this is like the magic of the LIC. This is the glue. This is the stuff. And I just wrote down, I think there are so many takeaways from all of these rich stories, but I wrote down just a few words that came to mind. So integration, so integrating IM skills in surgery clinic. Advocacy, so advocating for patients for whatever reason and with patients. Seeing that human connection. So connecting on a human level, even when your brain wants to tick through check boxes. Support, and it's the student-driven support. Enhancing continuity, so showing up in places where you can really enrich the care because you're enhancing that continuity. And then utilizing patient values to drive their care and to better understand what they want and identify with their values. So thank you all so much. I think we have questions. Time for questions.
Can I add a comment?
Yeah.
This just is coming from the Zoom chat, and this comes from Mandy, who I happened to have lunch with, and we were actually talking about this exact same thing. So I'll just reflect on this really quickly. She says, "These are great stories. And for those as preceptors, these things help our burnout as well. When you as students share this information with us, it helps us remember what we do." And I think that really resonates for me. I think what Mandy and I were talking about at lunch was that it was literally our students that got us through the pandemic and coming to work every day and at least having someone there who was excited to learn and excited to really engage with our patients. So I'll just extend my appreciation to all of you for not only being here today, but for your amazing work with our patients and caring and genuine authenticity and learning and everything that you bring that really lights up our lives too.
I thank you all for telling stories and being brave and getting up with things that I know have impacted you deeply and bringing them to the forefront here. We've talked so much over the last day or two about like this panel concept, and you guys bring it to life, right? They bring it to life in a way where you start to really see how this works like across health care systems and silos. We were going to do breakout groups for you guys But we're not going to do that because their stories were worth spending more time on. But I do encourage you to just make a mental note or two. Like, what did you hear in here? Not just about themes, but something you might do to try and activate the patient panel experience. And I am going to just wrap up with the patient side of this. So I think we could hear in the gratitude and the relationships that were built that that their patients felt like these relationships were valued, but that is borne out in the LIC literature as well. So Dr. Adams and Robbie Flick, Dr. Flick, and other colleagues did a study at Denver Health where they went back and combed through charts and found of the patients who had been part of panels of Denver Health LIC students, and really reached out to them, interviewed them, did an analysis. And what those patients expressed is they really valued this alliance. This worked both ways. And they voiced an improved patient experience because of having the LIC student be a part of their life and their health care and their well-being that year. And they actually talked about feeling like they were experiencing mitigation of some of the failures that had impacted them in the healthcare system by having this person who was invested in leaning in and giving power and voice to them. And while it wasn't a study that was looking at objective healthcare outcomes, the patients themselves were describing that they felt an improvement in their health outcomes and some loss when the students transitioned. And they came up with a model that kind of walked us through that. And there's actually another study that came out of the VA in Minnesota and their LIC. And this one was taking, so the students had cohorts, and then the physicians, they actually did a mixed method study where they controlled. So they interviewed and did studies with patients who were in the LIC panel of a given preceptor and patients who had that PCP but didn't work with a student. Okay, so they matched them for age and complexity for whether they had the student or whether they didn't. And what do you know, the students or the patients who had worked with the LIC student, even though their doc was the same, the ones who had the student reported greater satisfaction with the way that their doctor was communicating with them. They reported greater satisfaction with their provider's knowledge of their personal history. They reported greater agreement that the provider themselves was looking out for their best interests, and they were selecting top box scores more frequently when it came to these formal surveys that we all know our patients fill out on us. So I think that's really interesting. It tells me, where's the proxy in there is that the doc is spending more time with their patient because they've got the student in the room. Maybe a little bit of it, but I actually think it's a lot of what these guys are bringing to the patient care experience that then sort of ends up influencing the larger patient-doctor dynamic in ways that are positive. So that gives me a lot of hope for what our patients bring to our physician relationship with our own patients as well. So thanks again, everybody. Give them a round of applause.
Great. Huge appreciation for our students. Thank you so much for coming.